Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Sajid Majid, consultant child specialist. Today I'll discuss an important short case which often come across in exam. Your command will be do motor system examination and relevant. First of all, introduce yourself, take informed consent. Patient should be in panties or exposure should be at least mid chest to mid thigh. Make position of child, head should be straight, arm should aside, leg should be straight, and whole body should be in one plane. While making position, you may got idea of weakness. Now start with inspection. First from foot end, then from side end. Count respiratory rate, observe for NGs, Foley's, posture, and any abnormal facial weakness or deviation. Do sign of meningeal irritation as your command is motor system examination. Talk to patient to check his orientation and memory, then ask for gait. If patient cannot walk, say him to raise one leg, then second leg, subsequently one arm, then second arm. It will give you bit clue of affected limbs. But if patient can walk, then do whole gait examination. Gait would be circumductive. If no ataxia observed during gait examination, don't do cerebellar signs. Then do fog and reverse fog test. First walk on medial edges of foot, then on lateral edges of foot. A patient with stroke cannot do this. Do motor system examination of lower limb. Tone will be increased, power will be 2 by 5, reflexes will be increased, Babinski positive, and Cronus will be positive. Now identify where is lesion in cerebral cortex or brainstem and what is lesion, crossed or uncrossed. If lesion is above the brainstem, then it would be in cerebral cortex, corona radiata, or in internal capsule. Lesion in cortex leads to monoplegia, lesion in corona radiata leads to hemiparesis, and internal capsule lesion leads to dense hemiplegia. If facial nerve is involved, it would be uncrossed. Also assess clinically which lobe is involved and also do higher mental function. Marked irritability would be due to the frontal lobe involvement. Memory loss can be checked by asking Kalma, and if it is defective, temporal lobe would be involved. Parietal lobe can be checked by checking the stereognosia and agraphia. If patient is unable to recognize things with closed eyes, this would call the stereognosia. And if vision is defective, occipital lobe would be involved. Then do the cranial nerve examination quickly. If any of cranial nerve is involved of one side and weakness is on other side, it would be crossed. Quickly make H for third, fourth, sixth to check midbrain, frowning and tight closure of the eye for 7 nerve. Say patient for showing uvula by saying ah, and say to protrude tongue to check 10, 11 and 12. Now do the general physical examination to rule out the cause. Hands for pallor, nails for clubbing, cyanosis for congenital heart disease and subacute bacterial endocarditis. Check pulse. BCG for tuberculosis, lymph node for TB, lymphoma and leukemia, eye for conjunctival hemorrhages. Do CVS examination S1, S2 for congenital heart disease and check liver and spleen for leukemia. Petechiae and bruises would also be checked over. Do abdominal reflexes in diamond shape, away from umbilicus. Then do blood pressure and ask for fundoscopic examination. Then cover the patient and say thanks to the patient. Now present the case in comprehensive manner. A 7-year-old child who is conscious, cooperative during my examination, having respiratory rate of 20 per minute, pulse rate of 110 per minute. He is pale, having petechiae and bruises all over body of different size, shape and ages. Largest one is 2 into 1 centimeter over abdomen. He is not able to walk, having hemiplegia of right side with normal bulk, increased tone, power 2 by 5, breast reflexes with positive clonus of right side. Superficial abdominal reflexes exaggerated of affected side. All accessible cranial nerve examination is normal. First and second heart sound is normal intensity. No hepatosplenomegaly or lymphadenopathy. On the basis of my examination, my differentials are stroke secondary to aplastic anemia, stroke secondary to leukemia, or myelodysplastic disorder. Sir, I will do following test to confirm my diagnosis: blood complete picture with peripheral film and retics, serum LDH and uric acid, non-contrast CT scan, MRI brain. Sir, I have also planned to do the bone marrow examination, MRCT angiogram and MRCT venogram. Now, if your examiner would ask about any test, then describe the test like CP with peripheral film and retics. In all cell line will be decreased in case of leukemia and aplastic anemia, but blast cell will be present only in case of leukemia, and in case of aplastic anemia retics would be less than 0.1%. LDH and uric acid would be increased in case of leukemia. Non-contrast CT scan will show ischemic or hemorrhagic changes of within 24 hours. MRI brain we can also show the tumor, secondary mets, bleed or ischemia. Then bone marrow examination to differentiate the leukemia and aplastic anemia.